Good morning, everyone. We welcome you to our IC on Controversies in Ocular Oncology. So I will request the co-instructors to come on the dais. So we have with us Dr. Swati Kaliki, who is the head of Operation Eyesight Universal, L.V. Prasad Eye Institute, Hyderabad. We have Dr. Vishal Rawal. Vishal is a consultant vitreoretina and ocular oncology at L.V. Prasad Eye Institute, Hyderabad. We have with us Dr. Shahid Alam. He is a consultant, Shankar Netralaya, ophthalmic plastic surgery, Shankar Netralaya, Calcutta. So, Shahid, please come up. And we have Dr. Shubha Javhar. Dr. Shubha is a professor at the Government Medical College, Aurangabad, Maharashtra. Madam, please come on stage. So we will be starting with eyelid malignancies, surgical or conservative management, with Dr. Shubha Javhar as our speaker.
At the outset, I thank the organizers of this AIOC meeting, Kolkata, and Dr. Anasua Ganguly for letting me present this topic on eyelid malignancy, surgery, or conservative treatment. The first slide, it's not moving, yeah.
So the timer is set on 12 minutes, it should be. Okay.
So we go on to this topic of eyelid malignancy. So once a patient like this comes to you with a small tumor mass near the medial canthus, what options do you have and what will you like to do? And in such a case with an extensive malignancy where you can see the nose is puckered and lifted up and all the ethnic size involved. So in such cases, what options do you have for treatment of these malignancies? So factors to consider will be the patient's age, any previous medical history, any present state of health of the patient, and the importance of cosmetic preservation, the patient requirements, and tumor characteristics like the number of tumors, the size of the lesion, whether the borders are well defined or not, the site of the tumor, any history of previous radiation, high or low risk characteristics of the tumor, and to this I would add socioeconomic status, which is very important in our country. Depending on this, the patient will follow up with you and come for the further treatment. So these are the utmost factors to consider the treatment of this patient. So various modes of therapy are available for this eyelid malignancies. The first and foremost would be surgery. Then you have alternative treatments like cryotherapy, external beam radiation therapy, topical chemotherapy, laser, systemic chemotherapy, photodynamic therapy, biologic therapy, and targeted therapy. So surgical management, of course, the treatment is individualized to the patient. As I told you, the factors to be considered have been labeled, and situation, the tumor characteristics, and histological subtype. So outlines for surgery will be biopsy, and generally we go on to the excisional biopsy or surgical excision. So surgical excision has to be a wide local excision. So remove the tumor along with a clear 5 millimeters margin, and you should consider intra-op margin control in the form of standard frozen section or Mohs micrographic surgery, which is a layered excision and minimizes healthy tissue sacrifice. So eyelid reconstruction is carefully considered, as both function and aesthetic outcomes are important, of course, depending on the extent of the tissue removal, site, and size of the tumor. So small defects can be closed directly with or without cantholysis. Moderate defects up to half of the lid will be closed by Tenzel's flap, and larger defects over half of the lid will need Hughes tarsoconjunctival flap or a Cutler-Baird bridge flap. Or you can use Mustardi's cheek rotation flap, and the recent ESOPRIS learnings Richard Allen has proposed composite lid flap from the other lid. So defects less than 50%, as I told you. So this was a case that came to me with a sebaceous gland carcinoma, looked like on the upper lid, and therein we went ahead for wide local excision and a tensile flap reconstruction, and you can see the tumor was excised well and reconstructed very well. So another such a large mass covering almost the 3/4 of the upper lid with an ulcerative growth. For her, we went ahead with Cutler bed technique, wherein we resected the tumor and made a bridge flap from the lower lid in the first stage, and the second stage we cut it and upper lid healed nicely with good lid movements. This was another case with an ulcerative growth at the near the lateral canthus in the lower lid, the lateral part, and for him we went ahead with a Mustardi's cheek rotation flap, wherein the reconstruction was done very well. This was another very huge mass involving the complete lower lid, the medial canthus, the medial part of the upper lid, wherein it was excised completely to leave a very large defect which was covered with Mustardi's cheek rotation and a glabellar flap. So here now with this very large tumor, we can consider neoadjuvant chemotherapy, but for this case, the lady had come after 10 years of her taking care of this tumor at home, and now once she comes to me, I had no other option but to go in for direct excision and reconstruction. So these are the factors that need to be considered. Orbital invasion here in extensive cases, we have to go for exentrations. So in such a case, so cryotherapy is another modality of treatment, but it is used rarely because of high rate of recurrence. Then radiotherapy, yes, of course, it is curative and it can be used as an adjuvant to surgical excision or palliative in advanced and extended lesions where surgery is not suitable or the patient is not fit for surgery, where we can give around 50 to 74 grays of external beam radiotherapy. Now this minimizes the need for reconstruction, so you can give it before surgery. It can be used for removal of recurrent tumors and extensive tumors, again that cannot be adequately removed, and in frail patients who are surgically unfit. In sebaceous gland carcinomas, this can be used to shrink the tumor before surgery, and those who are spreading locally or into the orbital bone, again you can use them, and in large, very large basal cell carcinomas where the margin is positive and perineural invasion is there. So adverse effects, of course, are there: keratinization and loss of lashes, necrosis, telangiectasia, and ectropion formation, and irradiated tissues show poor healing, so the future treatment is difficult. So then we have topical chemotherapy where 5-FU or mitomycin C can be used. Now 5-FU in the form of Effudex skin cream is used twice a day, and for this then you have redness and pain and sensitivity to light. So this can be used in sebaceous gland carcinomas with pagetoid invasions, and for this you can also use topical mitomycin C, which is rampantly used here, 0.04% 4 times a day with weekly offs. Then laser therapies can be used, and my skin colleagues have been using this, and for small tumors, so CO2 and argon or Nd:YAG laser can be used. Then you have neoadjuvant chemotherapy, which is, as I told you, being used in aggressive sebaceous gland carcinomas. So cisplatin, doxorubicin, 5-FU, and mitomycin C can be used. Now, Dr.Anasua, this is a slide she has shared with me. And this patient was treated in LVPI, a 46-year-old male with extensive sebaceous gland carcinoma, where a spontaneous resolution was possible after giving him systemic chemotherapy. So this was an extensive case wherein the adnexa and the orbit was involved. So neoadjuvant chemotherapy with cisplatin and 5-FU were given for 6 cycles, and chemo reduction that is 60 to 75%. You can see here in the other pictures where they helped in performing the conservative surgery in extensive sebaceous gland carcinoma. So of course you should go ahead with such treatment. Then you have biologic therapy, that is biologic agents like imiquimod used in superficial basal cell carcinomas, but the patient needs requires monitoring for possible recurrences from buried tumor cells under the skin. So imiquimod is used as 5% cream for nodular basal cell carcinoma. This is an OD application 5 times per week, and it has to go on for many days because recurrences have been reported, but the lesions less than 10 millimeters are said to give 100% cure. Yeah. So this paper has shown that 81.8% of tumors more than 10 millimeters give a 3 years histological clearance. So then targeted therapies, there where drugs which target the tumor cells by specific cell cycloantigens to disrupt the tumor cell growth and division are used here to treat some cases of advanced or metastatic basal cell tumors which are not suited for any other conventional treatment option. So Vismo they give is available. This is a hedgehog pathway inhibitor to treat basal cell nevus syndrome or Gaulian syndrome, where numerous cutaneous lesions on the face and periocular region are seen. And this is used for locally advanced or metastatic basal cell carcinomas or in relapses. This reduces the size of the tumor and has to be given orally 150 milligrams per day for months. But resistance is of course a challenge, and we don't get this here. That's why we are not using it. So let's hope we get to use this in the near future. These are my references. Thank you so much.
So thank you, Dr. Jawar, for nicely elucidating all the treatment modalities available for treating eyelid malignancies. Next, I will request Dr. Shahid Alam to speak on orbital apical tumors, resection versus radioablation.
Good morning, everyone. So, thanks, Anusua, for this opportunity and making me a part of this instruction course. So, orbital apical tumors are a real challenge owing to the complex anatomy of the orbital apex. So, as we all know that orbital apex is a closed, crowded space, and when we see the orbit, it narrows down at the apex, and then we have some important vital structures, some vascular bundles, and nerves going down from there. So any space occupying lesion which occurs in around the orbital apex is a real challenge both for the diagnosis and management. Because if you want a tissue diagnosis, you have to go and intervene in that area. Even if you want to remove it completely, so that's a challenge. So tackling the space occupying lesions in this area it's very difficult, and the management still remains debatable. It's controversial, if you speak to a neurosurgeons, so they would prefer going to that area, taking a biopsy or removing it completely, but the approach is it's quite complex, time taking, and sometimes not very cosmetic. And we as an oculoplastic surgeon, so when we encounter such tumors, we are in a real dilemma what to do about these kinds of lesions. So there are spectrum of tumors which can occur in this area. They can be cavernous hemangioma, schwannoma, neurofibroma, meningioma, glioma, lymphomas, and metastasis. So of course, when we see such a lesion in this area, so we have to rely a lot on our radiologist, who depending upon his experience gives us a working diagnosis of the mass. And in most of the cases, if you are sure that it's not a malignancy, it's mostly a benign mass, and it is causing a neural compromise there, causing a diminution of vision, then we have to take a call in those patients whether to go and intervene or to rely upon radiotherapy or radioablation. So I'll just go through few cases and share my experience in these kind of tumors. So surgical approach to the apex, as I already told, if the mass is at the apex but lateral to the optic nerve, you can go and remove the bone and try to access that area. But if it is medial to the optic nerve, that is become much more challenging, because then you have no other option but to rely upon the endoscopic approach. So these are the challenges, because visualization is quite poor. We don't have much of a maneuvering space. If something starts bleeding there, you can't reach there to cauterize the bleeders, and there is always an impending this thing for damage to nerves and the ciliary ganglion. So this is a case where you see a mass lesion in the orbital apex compressing the optic nerve here, and as you can see, it's there is a tail going on much beyond the orbital apex, and from these imaging features, it appears to be a orbital schwannoma. This is the disc picture of the patient. Vision is counting finger at 1 meter. So now what to do in such kind of a patient, whether to go and remove it, or you go and give radiotherapy. So we don't know whether schwannomas, or for that matter cavernous hemangiomas, they are radiosensitive or not, how much they will shrink. We don't have much of an experience, and we don't have much of a literature on it. So because seeing the size of the tumor and it being in the lateral compartment, so this is a VEP picture. As you can see, the VEP is quite diminished in that area. So we went ahead and did a debulking, but the vision did improve much. So post-op vision remained 2/60. So actually that was again, patient didn't have a complete vision loss, and we had a tissue diagnosis. We came to know that yeah, it's a schwannoma. So this patient was then further observed for whether the tumor further increases in size in future or not. This is another case which I had operated recently. So this patient was referred to me, and like most of the oculoplastic surgeons, they had already counseled the patient. There are high chances of vision loss, but the parents were insistent to get it removed, mostly because of the cosmesis, because the patient had an exophthalmos and a squint associated with, and they wanted a tissue diagnosis for this mass. Vision was counting finger, there was gross RAPD. So I did a lateral orbitotomy, reached the area, and to my surprise, it turned out to be a dermoid cyst. It was a dermoid cyst sitting in the orbital apex area. So we were able to remove it, but we could not salvage vision. Post-op vision, patient underwent, patient completely lost his vision. He had initial vision was counting finger, and he ended up with no perception of light. So that's the impending damage of doing a surgery in this area. Now this is another patient. You see, there's a small lesion in the orbital apex, but then this has nicely compressed the optic nerve there, and you can see how the disc has become pale, and the vision is finger counting at 1 meter. So you cannot really go in this area and try to remove or debulk this mass. It's such a small mass sitting there. So we went ahead and gave radiotherapy to this patient. Our working diagnosis was cavernous hemangioma in this case, 40 gray in 20 fractions, and to our surprise, vision improved to 6, 9, and 6. And though there was not drastic improvement in the fields, but vision improved quite nicely from finger counting at 1 meter to 6, 9, and 6. And these are the post radiation disc pictures of the patient. And as you can see, there is improvement in the pre and post VEP also. And when you compare the size of the tumor, so whenever we give radiotherapy, so we don't see like there is a drastic change in the size of the mass. The radiologist who measures the mass, they will generally say that there is 30% or 20 to 40% reduction in the size of the tumor, but that reduction in size is sufficient enough to cause an optic nerve decompression, and in many cases regain the vision. This is another case. It's again a very small lesion sitting in the orbital apex. Vision was 636. So in this patient, we did a lateral orbitotomy, and vision didn't improve much. Vision more or less remained the same in this patient. So another case where the patient presented with mass, and the vision was counting finger N6, RAPD was present. This is 10-2 field of the patient, and this is the mass sitting here. See, so in this case also, the radiological diagnosis was an orbital apex cavernous hemangioma. So for this patient also, we decided to give radiotherapy. So CRT was given 50 grays in 27 fractions, and this patient also the vision improved to 6/9. And these are the pre and post radiation, comparative pictures of the fields of the patient. And in this case, you can see that the tumor has shrunk almost 30% here. This is the pre-RT and this is the post-RT imaging of the patient. So this is our data of our a small study which did at our center of 12 patients, and we did notice there was an improvement in the vision. Of course, we haven't compared like what was was there any difference in the patients who underwent surgery and the patients who took radiotherapy. But in the cases which I have described just now, we came to see that the patient who underwent surgery had a higher chances of losing vision or diminution of vision as compared to patients who had received radiotherapy. So, orbital apex lesion, be it a cavernous hemangioma or a schwannoma or any other lesion. So this is a paper which says that beware of the pair. So an apple-sized lesion, so it's less likely to cause optic nerve compression as compared to a pear-sized lesion, which really goes into the orbital apex and snugly fits in there and causes a nice compression over the optic nerve. And this is another paper, the Mastardi lecture, which speaks about the post-operative visual loss in patients undergoing orbitotomy, a case series of 14 patients who have described different mechanisms by which a patient loses vision. So, like most of us, like very commonly say that these patients have a high chances of undergoing central retinal artery occlusion. But actually, what happens in most of these patients they lose vision because of posterior ischemic optic neuropathy, the circulatory compromise which happens because of the inflammatory mediators that get released, and the post-operative vasospasm. So the PION is the most common culprit as compared to CRAO, which is commonly believed. And this is another patient of a series of orbital cavernous hemangiomas, where the authors have said that if the mass is just causing an exophthalmos without causing a visual compromise, those set of patients can be just observed instead of undergoing any intervention. So this is another paper on three-dimensional reconstruction using endoscopic intraorbital tumor resection. I don't have much experience on this technique. Yeah, of course we have done endoscopic decompression for tumors sitting at the orbital apex and lying medial to the optic nerve. But in this case also, in many of the times you will need help of an ENT colleague. So this is another paper where, as I told, where the authors have mentioned that PION is the most common culprit of the post-operative visual loss in this set of patients. This is another interesting case report of an orbital cavernous hemangioma which was managed by oral propranolol. So as we all know, propranolol is nowadays the treatment of choice for capillary hemangiomas. But yeah, these authors, they tried propranolol for cavernous hemangioma with nice results, as is seen in the pre and post imaging pictures. I also have given propranolol for few of my patients of cavernous hemangiomas, but there were not much improvement. So we have to in all these set of patients, so it is up to the surgeon, the physician, to take a call, like when should I go inside and intervene, whether I need a biopsy in this case, I need a tissue diagnosis in this case or not, whether I'm sure about the diagnosis which the radiologist has given me, should I go ahead with radiotherapy. So it's a real dilemma, and you have to balance the benefit and risk in these cases. So I'll just like to conclude by saying that a good surgeon knows how to operate and better surgeon knows when to operate, but the best one knows when not to touch this kind of patients. Thank you.
Thank you, Shahid. I think a good synopsis was that Moritz paper where he talked about the apples needs to be excised and the pears needs to be radioablated. So thanks for elaborating on all the possible situations for orbital apical tumors. So next we move on to Dr. Vishal Rawal. Vishal will be talking on intraocular lymphoma, when to do biopsy, or will a OCT-based diagnosis suffice? Over to you, Vishal.
Thank you. Thank you, AIOC committee and Anasua for inviting me for this instruction course. I have no financial disclosures. So before I move on to the topic which was given to me, the dilemma whether you want to use OCT as a diagnostic modality to diagnose primary vitreous lymphoma or you want to have a gold standard biopsy. I think little bit of information about vitreous lymphoma is very, very important. So we all know it is a masquerade syndrome. It does mimic many of chronic uveitic conditions, might be some intraocular malignancies also. From the general oncology principle, we all know intraocular lymphoma involves two major compartments in the eye. One is vitreoretinal and as the uveal or the choroidal lymphoma. Both are two distinct entities having different morphological, immunophenotypical as well as genetic features. So I think the first distinction should be made what you are dealing with, whether it is a vitreoretinal lymphoma or it is a uveal lymphoma. Second distinction you want to make whether the lymphoma is seen primarily in the eye or there is a lymphoma somewhere else in the body, that is systemic lymphoma, and now it has involved the eye compartment, and that's why it is a secondary vitreous lymphoma. So I think that distinction needs to be made clear cut before you jump into making any kind of diagnostic dilemma, what investigations you want to do or what treatment you want to do. So I will be dealing, my talk will be dealing related to primary vitreoretinal lymphoma only, and we all know it is a subset of a lymphoma which primarily involves the CNS compartment. So why it is important from the ophthalmologist point of view, because we all know whenever the vitreoretinal lymphoma primarily involves the eye, we know in close to around 60 to 90% of patients in next 1.5 to 2 years you see the CNS compartment gets involved. So I think as a ophthalmologist our role is limited to the eye, but the overall survival or the patient mortality will be related to the CNS compartment involvement. So our role is very, very important whenever we are diagnosing any case of vitreoretinal lymphoma. On the contrary, the patient has already been diagnosed to have a central nervous system lymphoma. We know in 15 to 20% of cases they might be having a either concurrent or subsequent eye involvement. So we also need to kind of have a word with the neuro-oncologist that whenever they are diagnosing any case of CNS lymphoma, it is very important that they do refer the patients to the ophthalmologist, particularly when the patients complain of vitreous floaters or any diminution of vision. Diagnosis, as I told, I think the main diagnosis is our clinical examination, which includes both slit lamp and the anterior vitreous examination to look for any vitritis, vitreous fibrils or vitreous opacities. Fundus examination on the clinical examination is very important, which shows the presence of multiple discrete yellow subretinal infiltrates. OCT, yes, over the time the OCT has evolved and the newer advances in OCT has helped us to kind of look more into detail, particularly related to the involvement of specific layers in the retina, which gives a clue what we are dealing with. And yes, I think biopsy, particularly taking from the aqueous, vitreous or the retina or the sub-RP space, has kind of improved our understanding not only related to the pathogenesis but also improved our diagnostic modality in terms of false true positivity to look for either direct cytology to look for large B lymphocytes, immunohistochemistry markers, particularly CD20 positive, and cytokine related ratios, IL-10 to IL-6 ratio, and now the newer what we have is mediated mutation. So usually the patients presents with either unilateral or bilateral involvement. The most common presenting symptom is either blurred vision or decreased visual acuity with floaters. Vitreous is the most important compartment which gets involved in primary vitreous lymphoma, and usually you see this vitreous large clump-like opacities as compared to any vitritis we usually see in uveitis, where it is kind of vitreous cells, but here they are kind of clump or opacities. Subretinal or sub-RP infiltrate, I think that is very, very classical description for any primary vitreous lymphoma. However, same kind of descriptions can be sometimes mimic ocular syphilis or tuberculosis, or sometimes even a full thickness retinal necrosis. So I think as we all know, it is a masquerade, so it can present in any form. So you need to distinguish these lesions from any other inflammatory or infective uveitic condition. So this was one of the paper where they have studied the OCT features of primary vitreous lymphoma, and they found most common feature what they could found in that study was the presence of hyperreflective foci in the posterior vitreous or the vitreous vitritis, followed by retinal lesions, subretinal lesions, and intraretinal RP lesions or RP undulations. So we also thought, let us relook our data and find out what we could think of any OCT related biomarkers which could help us to diagnose these cases and also help us to prognosticate in terms of if we are doing any kind of treatment, does OCT helps us into prognosis. So this was a retrospective short kind of cohort of 18 eyes of 10 patients. We all know it is not a very common disease, so it is very difficult to have a large prospective study. So we just looked at our OCT patients of primary vitreal lymphoma who had all biopsy proven primary vitreal lymphoma. So mean age was 63 years, delay in diagnosis. As we all know, these are patients who have been treated with oral and topical steroids, have a waxing and waning course. So always there is a delay in diagnosis, either from the retina point or from the uveitic point of view. And if nothing is working, then there is a presumptive diagnosis of vitreal lymphoma, and then their patients are referred to the oncology clinic. History of corticosteroid usage is usually seen in most of the patients, and it is very, very important if you are planning for any biopsy or anything, you make sure that at least 2 weeks of steroid cessation is very, very important to increase your yield of biopsy. And CNS involvement was seen in close to half of our patients. The OCT features, what we could demonstrate in our short study was presence of vitritis or vitreous cells. That was seen in close to 2/3 of patients. Subretinal deposits, as you can see, was marked in yellow arrows, in blue arrows. It is close to half of patients. Important feature what we highlighted is RP detachments and undulations, which was seen in most of the patients. Sub-RP deposits, what we see classical hallmark of primary vitreal lymphoma, which has been described in the previous literature also, was seen in only 40% of patients. So cystoid macular edema, yes, it is a very common entity which we see in inflammatory and infective uveitis conditions. But yes, for some reason, we don't see that much of cystoid macular edema, particularly in case of primary vitreal lymphoma. So this is just a case example where you can see this is a patient with right time perivascular sheathing and some kind of small yellowish discrete lesions in the infratemporal quadrant. Important finding in the left eye, you could see there is a media hazy secondary to vitritis. You can see hemorrhage at the macula with subretinal lesions. Again, multiple discrete yellowish subretinal lesions with a large placoid lesion seen at supratemporal quadrant. And this finding or this clinical examination over the time, I think this has kind of helped us to make a initial diagnosis of vitreal lymphoma. Investigations, because this patient was referred to the oncology clinic, all the uveitic related systemic investigations were all negative, and we made a provisional diagnosis of both as primary vitreal lymphoma. OCT, again, what we usually do in each and every case of vitreal lymphoma, it does helps to kind of reach to the diagnosis, and you can see in the vitreous, you could see presence of multiple hyperrefractive foci, which are very classical feature you see in case of vitreal lymphoma. Presence of multiple focal discrete hyperrefractive nodularity both in the RP and sub-RP space, and RP detachments. In the right hand side photograph, you can see even there is RP lymphoma cell infiltration from the RP space into the inner retina also. So that is not very commonly described, but yes, you do see in close to around 10 to 20% of cases. This patient was treated with 8 doses of bilateral intravitreal methotrexate. Vision did improve, and you see these lesions respond beautifully to your initial couple of injections of methotrexate only. And the OCT, again, it shows how beautifully it shows the resolution of your sub-RP as well as the vitritis compartment involvement of the lymphoma. So OCT not only helps us to diagnose the cases, but also helps to prognosticate when you should stop your treatment, because that is the most important question the patient is going to ask you: how many injections, how frequent injections I'm going to take. Yes, as per the literature, they say they need to take 25 injections over 1 year, but practically it is not possible that patient is going to receive that many injections because of logistic issues and sometimes related to intravitreal methotrexate toxicity also. So I think OCT does helps in some kind of quantification how the patient is responding to your treatment and when you need to stop the treatment. So post-treatment, we could see, I think most important, there was sub-RP deposit resolution was seen in all the cases. RP detachment resolution was seen in 88% of cases. And ultimately, the RP infiltrates which didn't resolve led to fibrosis and outer retinal layer abnormality. So learning point, what I would say, I think it is important if you do an histopathology of the retina, where very rarely we do enucleate these cases, but once in a while, this is one of the gold standard picture which I could get from the literature. You see how closely it resembles an optical coherence tomography picture. So I would say OCT does helps us to diagnose the cases. It resembles and can be a surrogate marker for your biopsy. But yes, it is non-invasive. It can be performed multiple times, and it can be used for follow-up of PVRL cases. But disadvantage, we all know, it is not a highly suspicion for winter lymphoma. It is not definitive. OCT features what we see nodular or band-like hyperrefractory spots is usually seen in 50% of cases only. And as we all know, lymphoma does mimics many of the inflammatory and non-infective uveitic conditions. So unless and until we have the molecular evidence of malignancy, it is very difficult to label a patient for lifelong that they're suffering from an underlying malignancy, which might have an impact on not only in the eye morbidity but overall mortality also. So I think from that aspect, I feel, as I'm a retina specialist, but I'm ocular oncologist also. So sometimes I have to turn my hat and say that now I am being ocular oncologist, I have to have a molecular diagnosis or a histopathological confirmation before I prove that this patient is having an underlying systemic malignancy, particularly related to the eye. So in that context, because I'm retina specialist, I can easily go to that space where the lymphoma cell infiltration is there, and biopsy is not that kind of difficult, particularly from the retina point of view. So we do take biopsy both from the vitreous compartment, from the subretinal space or the sub-RP space, and very rarely if your initial couple of biopsies comes negative but your clinical implications are very high, your suspicion is very high, then you go for last resort as full thickness retinochoroidal biopsies. What we usually do with this biopsy material or specimen is we look for direct cytology to look for large B cell lymphocytes. Immunohistochemistry, what we want to look for is CD20 positive and negative. Sometimes, yes, you do see T cell dominated lymphoma also, very rarely, less than 1%, but majority of all these are CD20 positive large B lymphocytes. Molecular diagnosis, yes, now it is in last couple of years, I think people have kind of turned over to next generation sequencing and using PCR and mutation for MID mutation. But right now in India, I think very few centers they are doing it. But again, the positivity for this mutation for the underlying diagnosis of vitreoretinal lymphoma is close to around 60 to 70% only. So this is one of the case. Again, you could see in clinical diagnosis, you see these multiple discrete yellowish subretinal lesions, which are very, very classical of vitreoretinal lymphoma. You do an OCT. Again, OCT does shows very classical hyperrefractive foci in the vitreous as well as in the sub-RP space. Biopsy, what we do is we take the biopsy from the undiluted vitreous using low cutter, that is close to around 50 to 1000 cut rates per minute. We do tell the sister to aspirate the material if possible under air so that we can increase our yield of undiluted vitreous. Followed by then we take the diluted vitreous specimen close to around 2 ml, or if possible then we ask to sister to send the whole cassette fluid for your cytology. And last, what we have done in last couple of years, we have changed our technique. We are directly taking the biopsy from the sub-RP space, as we can see on the OCT, where we know there is a most important infiltration of lymphoma cells which happens in the sub-RP space. So using an intraoperative OCT as a guide or as a tool, it does helps us to increase our yield from 40% to 70%. So I think this is something what we have done in the last couple of years, which has improved our positivity rate for vitreoretinal lymphoma. And this is the cell block which we prepare from the subretinal fluid or sub-RP space, and it does shows diffuse large B cell lymphocytes which are positive for CD20. And post-treatment with 3 cycles of biweekly methotrexate, you see how it beautifully resolves to your methotrexate injections. Tips I would say for the beginners who wants to take biopsy for vitreoretinal lymphoma, I think make sure you take diluted, undiluted vitreous specimen. Cut rate should be as low as possible. Make sure you have a word with your pathologist. Preferably the pathologist should be within your operating room. If not, for any reason, if you are not able to send the specimen on the same day or within 2 hours, you should fix it in 70% absolute alcohol, and make sure all these patients you kind of stop your systemic steroids at least 2 weeks prior to you take up them for biopsy. So advantages of biopsy, as we know, it is a gold standard. It not only has a diagnostic but also a therapeutic option, because you are clearing all the vitreous debris, vitreous opacities. So post vitrectomy, usually patients will always feel good that yes, vision clarity or the vision has improved post your diagnostic vitreous biopsy, and it does helps to monitor patients on long-term follow-up. Challenges, again, small sample size, delicate tissue, need for immediate pathological processing, and a good cytologist who could understand and look for diffuse large B cell lymphocytes. Negativity is close to 50% of cases, and some cases do require more than 1 biopsy. To conclude, I would say I think PVRL is a great masquerader. OCT, I would say, I think from the non-invasive point of view, it is a very important diagnostic tool and does help not only in diagnosis but also in prognosis. Biopsy, yes, I think from the oncology point of view, we know most of the cases of vitreoretinal lymphoma ultimately involves the CNS compartment. So unless and until you have diagnostic confirmation, your neuro-oncologist is not going to start on any kind of systemic chemotherapy if there is a CNS involvement. So from that aspect, if we have some kind of gold standard biopsy proven primary vitreoretinal lymphoma, then we might be able to convince neuro-oncologists to even start prophylactic systemic chemotherapy for the eye compartment. So yes, it is difficult, but I think that's what I would say. I think OCT and biopsy both goes hand in hand, and depending upon the patient to patient case basis, we might decide what we want to use as a diagnostic modality for primary vitreoretinal lymphoma. Thank you.
Thank you, Vishal. So now I request Dr. Anasua Ganguly Kapoor to talk on ocular surface squamous neoplasia. So she practices ocular oncology at KVC campus of LV Prasad Eye Institute, Vijayawada.
Yeah, thank you, Swati. So in the next few minutes, I will be talking on topical fluorouracil versus interferon in the treatment of ocular surface squamous neoplasia. I have no financial interest to disclose. So talking of the two most commonly used pharmacological options in OSSN, interferon alpha-2b and 5-fluorouracil, which one is better? So let's find out. So interferon alpha-2b is a recombinant glycoprotein, a cytokine with antineoplastic and antiviral properties. So the mode of action is it improves the T-cell mediated immune response and also inhibits angiogenesis, whereas 5-fluorouracil is an antimetabolite. It inhibits non-competitively the thymidylate synthase, which interrupts the DNA and RNA synthesis in the rapidly proliferating tumor cells of OSSN. So when can we choose these agents to treat OSSN? So these days it is the primary treatment modality pharmacotherapy for OSSN. So it's basically an effective alternative to surgery, what we call as immunotherapy or a chemotherapy. So it can be used as an adjuvant to surgical excision, what we call as immune or chemo reduction or prevention. I will come to that. And for treating recurrences. So what do we mean by immunoreduction? When we have an extensive OSSN with basal diameter of more than 15 millimeter or more than 6 clock hours of involvement, we need to reduce the size, or for that matter, many of these cases just goes away with the treatment, with the use of chemotherapeutic or immunotherapeutic modalities. But these are absolute cases where you can't go ahead and do a surgical excision because we will end up with a lot of limbal stem cell deficiency. So immunotherapy is specifically for corneal OSSNs. For this particular case where you see there is a sheath of cells on the corneal surface, here you can't go ahead and do a excision biopsy, and these cases respond very well to this pharmacological therapies. And for recurrences, immunoprevention is when histopathology, so when you have excised lesion, histopathology shows margin positivity, we go ahead and treat these patients with these pharmacological modalities for a period of around 3 months. So moving on to the reconstitution of the drug, it is fairly simple for both interferon alpha-2b and 5-fluorouracil. So interferon is usually available as 3 million international unit or 5 million international unit as pre-filled syringes. From there we reconstitute and make 1 million international unit eye drop with using lubricants or distilled water as diluents. Similarly for 5-fluorouracil, it is extremely easy. 1% aqueous solution we make, 1 ml of 5-FU we mix with 4 ml of sterile water. Administration, interferon alpha-2b, as we all know, 4 times a day, and there's no drug holiday. Whereas for 5-fluorouracil, there's a drug holiday. We use it for 1 week and then pause it for the next 3 weeks. But for the injection, interferon alpha-2b, You can, what we usually prefer, but it differs from different, from different locations. The dosage use differs, but what we use in our institute is once a month, whenever required, not in all cases. So the advantages of injection include direct delivery to the tumor site, more rapid tumor resolution, and ensured compliance. And 5FU, as we discussed, there's a 3 weeks drug holiday. So again, moving on to the storage, the cold chain maintenance is important for interferon alpha 2b to give stability to the drug. So we need to store it in the door of the fridge, and also the cold chain needs to be maintained while we are transferring the drug, giving to the patient. So what we usually do is we give it in a thermocol box with ice packs in it to maintain at the temperature between 2 to 8 degree. But as you can understand, for patients from a low socioeconomic background, like for farmers and all, maintaining the cold chain itself is a difficulty. So there 5-fluorouracil stands out because we need not keep it inside the fridge. Moving on to the outcomes with both interferon and 5-fluorouracil. So response rate for interferon has been differently stated from 80 to 100%, with a mean resolution time of around 4 months and a recurrence rate of around 8%. Whereas 5-fluorouracil, the response rate in different studies have been differently quoted, but we recently looked into our patients in LV Prasad Eye Institute in the Indian subset, and we found the response rate to be 88% with just primary 5FU therapy. The rest, 12%, required some additional treatment for complete resolution. The mean resolution time was around 2 months, which is again a quicker resolution compared to interferon alpha 2b. The recurrence rates were also comparable, 7 to 10%, but in our study we got it around 2% at 6 months follow-up. Moving on to the adverse effects, interferon has mild and transient adverse effects like conjunctival hyperemia, ocular irritation, superficial punctate keratopathy, follicular conjunctivitis reported as less than 5%, whereas 5-fluorouracil, again the complication rate is around 7 to 10%, and similar, most commonly being conjunctival hyperemia and sterile keratitis, some lid edema, punctal stenosis. But what we usually see in these patients is that that the conjunctival hyperemia usually comes down during the drug holiday period. So for the injectable interferon alpha 2b, the flu-like syndrome with myalgia, fever is reported, again with less than 10% of cases. So here, but all of them are mild and transient, the side effect profile. For 5-fluorouracil, punctal stenosis, and this is how usually we see there is some amount of redness seen in these patients. Moving on to the drug cost, again interferon is not very costly, but one vial costs around 800 rupees, whereas one ampule of 5-fluorouracil costs around 11 rupees, and from one ampule multiple vials can be made, so the reconstituted drug cost comes to around 2 rupees. So 5-fluorouracil is much cheaper compared to interferon alpha 2b. So it is important while we are discussing about pharmacological options for treating OSSN to understand when not to consider these immuno and chemotherapy whenever the diagnosis is in doubt. So these days we really don't go ahead and do a incision biopsy for all cases, but whenever the diagnosis is in doubt, it is good that we just go ahead and do some incision biopsy, establish the diagnosis, and then go ahead with pharmacotherapy. Whenever the depth of involvement, we need to understand that these are options only when there is no involvement of the sclera or there is no intraocular extension of the OSSN. Whenever there is a adjacent structure involvement, we can't use these pharmacological therapy. So whenever the depth is in doubt, better not to use them. And like the T3 stage involvement of the adjacent structures, intraocular, cornea, fornix, tarsus, punctum, lid, best not to consider. Patient compliance is extremely important whenever we are giving pharmacotherapy. The patient needs to come back every month, so it's best to discuss with your patient at the time of starting the therapy. And if the patient is not ready to come back, best to go ahead and excise. And we see many patients are routinely getting pharmacotherapy post-surgery. That is not what is required. We only advocate use of pharmacotherapy post a wide excision only when the margin is positive, not in all cases. So just to summarize what we just discussed. So both interferon alpha 2b and 5-fluorouracil, the reconstitution is easy. Both are effective with low rates of recurrence, but interferon has the best ocular surface tolerability, so the side effect profile is a little less compared to 5-fluorouracil, and the injection option is also available, which directly can be delivered to the tumor site and ensures compliance. Whereas 5-fluorouracil, the drug holiday is something with less frequency of administration, which is helpful to the patient. There is no storage problems as we see in interferon. A cold chain needs to be maintained there. It is cheaper compared to interferon, and the response is quicker. So considering all these facts, we need to be prudent while choosing which pharmacotherapy to use, the tumor characteristic, the patient profile, the ease of follow-up, availability of the drug, the burden of cost, all these needs to be considered before we decide on the treatment modality of choice for a particular patient. These are my references. I will acknowledge both my colleague Kavya and Swati for all help they extend in my practice. Thank you everyone for a patient listening. So with this, I will call Dr. Swati Kaliki to talk on retinoblastoma intravenous versus targeted chemotherapy.
Thanks, Anasua. Very good morning to one and all present here. So I think so we have heard about different topics in this session, starting from the eyelid tumors to the intraocular tumors, the surface and the orbit tumors. So now we move on to one of the common intraocular tumors that we see, that's retinoblastoma. And I think the field of retinoblastoma is changing in such rapid pace that every 5 years we are having a new mode of delivery of chemotherapy. So when there are so many options that are available, it's very, very important to understand when to choose which option so that the patient has the maximum benefit from the treatment that you're offering to the patient. So in this context, let's understand what are the various forms of chemotherapy that are available for retinoblastoma and when to choose that particular form of chemotherapy. So now the retinoblastoma management is not very simple that you just have an algorithm and you just follow an algorithm. It certainly is not. Though we follow protocols for management of retinoblastoma, but still there are many factors that we have to take into account before we choose the form of treatment for a patient. Now, the various factors that we include when we have to treat a case of retinoblastoma, they include whether the tumor is unilateral or bilateral, because your form of chemotherapy or the form of treatment also depends on that. What is the size of the tumor? Is it that we are dealing with a very small tumor or whether we are dealing with a very large diffuse tumor? Whether the macula is involved or whether it is not involving the macula, whether it is associated with vitreous or subretinal seeding, whether there are presence, whether that eye is likely to harbor high-risk features, what is the age of the patient, whether it's a very young patient, say you're seeing a patient who is just few days old versus a patient who is few years old. Your choice of treatment again depends on that. What is the general health status of the patient? If you get a very emaciated child, so obviously you have to again think of what form of chemotherapy you're going to give for that particular child. And if there is any significant family history, that is if one of the parent has already had retinoblastoma, if there is risk of that child having a tendency to develop other tumors. So again, your form of chemotherapy that you choose depends upon that. And of course, last but not the least, probably the most important, what is the expectation of the family from you when they get their child to you? Because there would be certain parents who would be like, okay, we will do anything, but we do not want the child to have side effects during treatment. Or there are parents who will be like, okay, what we want the child to be saved with both the eyes, but we cannot afford very expensive treatment. Do whatever you can. So I think we also have to take into consideration the expectations, the desires of the patient and the family as well. So with this, let's come to what are the various forms of chemotherapy that are available. So the most common form, which is the intravenous chemotherapy, which has been around now for almost 4 decades. And it's a great form of treatment for retinoblastoma. And now the recently evolving form of chemotherapy that we have is a much more targeted chemotherapy. And I think we are in a very fortunate era where chemotherapy is being given into every possible cavity of the eye. It's not limited to only the intraarterial. Of course, it started with the intraarterial and the subtenons, but now we have progressed that we are also giving chemotherapy into the vitreous cavity. We are giving chemotherapy into the anterior chamber. So essentially, we are giving targeted chemotherapy to every possible cavity of the eye. Now let's start with the most common form of chemotherapy, that is the intravenous chemotherapy. The standard protocol that is followed by most of the ocular oncologists across the world is the use of vincristine, etoposide, and carboplatin, where we give the drugs on 2 different days, where all 3 drugs are given on day 0 or day 1, whatever you count it as, and the next day we give only etoposide. And the general protocol, and here we are talking of only the intraocular retinoblastoma. We are not talking about the eyes with extraocular extension. So the standard protocol that we follow is we give 6 cycles of chemotherapy. And it can be in the form of standard dose or high dose. Generally, we give the standard dose. High dose we choose in very rare cases where it is advanced in both eyes. And this is the standard dose that is followed by the medical oncologists who help us with the dose. Now here are few examples of the eyes with the intraocular retinoblastoma, where you can see that on to your left you see a smaller tumor, or maybe to your right, and then there is a larger tumor that is present on the other side. Now these patients, which form of chemotherapy would you give? Again, it would depend on whether it is a unilateral. If these both eyes are belonging to the same patient and we are talking of bilateral retinoblastoma, of course you have 2 choices. One is you can give the intravenous chemotherapy, or you can do a tandem intraarterial chemotherapy where you give intraarterial chemotherapy to both eyes. In the West, yes, there are groups where they do the tandem intraarterial chemotherapy, where they do bilateral intraarterial, but that's not a common practice. In Indian scenario, again, there are various factors that we have to take into account, whether the patient can afford intraarterial chemotherapy to both eyes, and whether your interventional neuroradiologist is experienced enough that will cause minimal side effects during this treatment, because intraarterial chemotherapy can be associated with very serious side effects like the ophthalmic artery occlusion and the child losing the vision completely. Now this child has received intravenous chemotherapy, and you can see that the tumor has nicely regressed into a very, very small tumor and has had a beautiful response. Now here is another example, and these are the typical cases that we would see in our scenario, where they come with very advanced or large tumors in both eyes. And the intravenous chemotherapy definitely works very well even for the eyes with large tumors, where you can see that the tumor as such has reduced beautifully. Of course, it has left behind a large scar, which is going to cause a compromise in the central vision of the child. But nevertheless, we are able to save the eyes. It has its own side effects, of course, the intravenous chemotherapy, which can be a different session by itself, where each of the drug can have its own side effects. The most common being the carboplatin causing the ototoxicity and the vincristine causing the peripheral neuropathy. These are the common side effects, and of course they do have the temporary side effects which are expected with any form of chemotherapy, like the nausea, vomiting, and loss of appetite, all that you expect with any form of chemotherapy. Now next, understanding the targeted chemotherapy, that is the periocular chemotherapy, which almost I would say is obsolete now. Maybe only in countries where intravitreal chemotherapy is not yet in practice, they are still using it, but otherwise we hardly use this form of chemotherapy. It was used maybe about 10 years ago, but not anymore. So in this, the periocular chemotherapy, carboplatin is the drug which is injected into the subtenon space. And here is an example. This is a very old case where we had used the subtenon's carboplatin. But today, if I would be treating this case, I would rather give intravitreal chemotherapy than a periocular carboplatin. So this is the child before chemotherapy. Then after chemotherapy, you can see that before chemo, if you notice, there is an endophytic portion of the tumor that is there, and after chemotherapy, the vitreous seeds just got dispersed into the vitreous cavity. And so this patient, and we know that when we are giving intravenous chemotherapy, the minimal drug is delivered into the vitreous cavity, so it will not cause much effect on the vitreous seeds, though some amount of reduction is seen. So the child was combined with the subtenon's carboplatin, where you can see the child had very good response. And after 3 injections of subtenon's carboplatin, the child did very well along with the intravenous chemotherapy. But of course, the challenges with the subtenon's carboplatin, those who have seen cases in the era where we used to do, is it causes fibrosis in the quadrant wherever you inject. So each time we used to change the quadrant. So if we have given in a say inferotemporal quadrant, then the next visit we change it to another quadrant, so that we are not increasing the fibrosis in that particular quadrant. The next, I think the most famous targeted chemotherapy is the intra-arterial chemotherapy. So in this, of course, it is done by an interventional neuroradiologist, where the chemotherapy drug is injected from the femoral artery, and you go through the common carotid, go into the internal carotid artery, and specifically target the delivery of the drug through the ophthalmic artery to the eye. So here is where the interventional neuroradiologist reaches till the ophthalmic artery, which is the first branch that comes out from the internal carotid artery, and then inject the drug. We typically use 3 drugs. This again, it varies from practice to practice, where few people use only single drug like melphalan, few people use only 2 drugs like melphalan and topotecan. We use melphalan, topotecan, and carboplatin combination. Now here is in fact the first case that we had treated with intra-arterial chemotherapy. This child had already received 14 cycles of intravenous chemotherapy and still had recurrence. So when a child has received so many cycles of chemotherapy, whether you would want to treat this eye again with intravenous chemotherapy, that it's because the cumulative dose of chemotherapy is going to cause side effects for the patient. So this patient, we chose to give intra-arterial chemotherapy. And you can see that after just 1 cycle of intra-arterial chemotherapy, the child had very good response. So this goes to say that I think we have to have an interplay between different forms of chemotherapy and know when to choose which form of chemotherapy. The next, the intravitreal chemotherapy. I think this is a landmark paper that I always like to show when I talk about this form of chemotherapy, because whatever we are doing today, the whole credit needs to go to Francis Munier, who showed that it is safe to inject in an eye with retinoblastoma, because it was traditionally taught that never put a needle into an eye with retinoblastoma, which probably doesn't stand true anymore, because we are putting needles now not just into the vitreous cavity but into the anterior chamber as well. So it is okay to inject a drug into the cavities. So this paper, this was the first paper that was published from the group, where they had used melphalan, and they showed that they had very good success rate, and none of the eyes developed extraocular extension after treatment. This again is one of the first cases that we had treated, where this child developed these vitreous seeds after 6 cycles of intravenous chemotherapy. You can see that there are multiple vitreous seeds that are present, not just adjacent to the tumor, but in the entire vitreous cavity. Now this patient, yeah, this patient, because intravitreal chemotherapy was kind of like, just we had started doing, we thought first let us start with the periocular carboplatin, and we had started and given periocular carboplatin for this patient. But as you can see, it didn't respond very well. Okay, let me move a little quickly. Yeah. So then we gave this child, so this was the starting point when the intravitreal chemotherapy was given to this patient, and the vitreous seeds completely regressed with 6 injections of intravitreal chemotherapy. At that point of time, we were using melphalan, but with time, we have realized that many of these patients who receive melphalan eventually develop side effects, and at this point of time, we prefer to use topotecan over melphalan for intravitreal chemotherapy. I can take another 2 minutes. Is that okay? Okay. So this is another example. The reason that I want to show you this case is sometimes we are so focused on globe salvage that we forget about our goal of also the vision salvage. So this is a case, this was again when we were using only melphalan, where you can see that there are large vitreous seeds that were present. And this was again after the child receiving 6 cycles of chemotherapy. We gave intravitreal chemotherapy to this patient, and just look at the color of 2 things that you have to look at: what is happening with the vitreous seeds and the color of the fundus as well. So if you see, definitely the vitreous seeds have disappeared, but along with the vitreous seeds, it has also caused a lot of toxicity. So the toxicity where you can see that the vessels almost are sclerosed. The temporal vessels, as you can see, they appear like the ghost vessels. So the vessels are sclerosed, and if you see the sheen that is seen in the first picture of a very healthy RPE is not there anymore in the 4th picture. So I think this was the case that we decided that we have to shift to a different form of chemotherapy, different drug of chemotherapy. We stopped using melphalan and shifted to topotecan, and our experience has been that topotecan causes minimal retinal side effects and has the same beneficial effect on the vitreous seeds. So melphalan, when we use at a dose of 20 to 30 microgram. If we use topotecan, we use 30 microgram in 0.15 cc. And now we have also started, hopefully next year I'll be presenting more data. We have also started doing high dose intravitreal topotecan for selective cases. We have specific indications for that, and we are seeing good response with that as well. The most important thing, I think, when we give intravitreal chemotherapy is to understand that though it is safe to put a needle in an eye with retinoblastoma, yet we have to be very, very careful that you do not want to be going into the eye through the retinoblastoma. So you have to choose a quadrant where there is no tumor, and the most important step, and which differentiates from other routine intravitreal injections, is that you do cryotherapy at the site of injection. So this is the triple freeze thaw cryotherapy being. So even before you withdraw the needle, you put the freeze, and through the freeze you're taking out the needle, just so that if there is any escape of the vitreous seeds, it is taken care of by cryotherapy. And we complete the triple freeze thaw cryotherapy cycle by completing 2 more cycles of cryotherapy at the injection site. Okay, I think I'll skip this. Yeah, going to the last bit, that's intracameral chemotherapy. Now, intracameral chemotherapy is the newest form of targeted chemotherapy that is currently available. And it is a very tricky form of chemotherapy. Not every case is suitable for intracameral chemotherapy, but yes, there are cases which will benefit from this form of chemotherapy as well. Our experience has been that we have done in 5 cases where we have given intracameral chemotherapy. 2 cases ultimately ended up with enucleation, but there are 3 eyes which could be saved with this form of chemotherapy. And again, the due credit goes to Francis Munier here again, where he was the first one to describe the bicameral technique of intracameral chemotherapy for aqueous seeding in retinoblastoma. So intravitreal chemotherapy we use when there are vitreous seeds. Intracameral chemotherapy we use when there are aqueous seeds. Now, what are aqueous seeds? Aqueous seeds are, you can see that there are tumor deposits that are present in the aqueous. They can be dust, spears, or cloud, or it can be a combination, which is the most common form. I will skip through these slides in the interest of time and just go to the technique. Okay, so the way that we do intracameral chemotherapy Intracameral chemotherapy is we go into the anterior chamber, aspirate the aqueous, then go into the posterior chamber, aspirate the aqueous from there, then we inject the chemotherapy in the posterior chamber and the anterior chamber, and then we do triple freeze thaw cryotherapy before we bring out the needle. So this definitely, it requires a lot of expertise. It cannot just be done in every case by anyone. So we have to be very careful when we are doing this particular technique. And here is an example. So this is the same case who had, so this is the case where there were aqueous seeds to begin with, and there were seeds that were present in the posterior chamber as well, which can be seen on ultrasound biomicroscopy. And you can see after one injection of intracameral chemotherapy, the child did very well where the aqueous seeds completely disappeared. We had given a combination of intracameral and intravitreal chemotherapy in this case. So I'll end with the last slide. So this is the case. So this is a one-eyed patient who has come to the clinic. He has already lost one eye because it was very advanced tumor. So enucleation has been done, and this is the advanced tumor in the only eye of the child. And because the enucleated eye also showed high-risk features, anyways, this child had to receive intravenous chemotherapy. Now, this is after intravenous chemotherapy. As you can see that the tumor is nicely reduced in size. There are few seeds that are still active, which we were doing focal treatment, but after few days, he comes back with this. By then, he had already received 12 cycles of intravenous chemotherapy, but now has these multiple vitreous seeds and tumor recurrence. So what would you do? So you definitely have to combine with targeted chemotherapy. So here we've used two forms of targeted chemotherapy, that is intra-arterial chemotherapy in combination with the intravitreal chemotherapy as well. And now this child has completed almost 6 to 7 years of follow-up and is still keeping the eye. So I think whenever we talk about chemotherapy, we have to choose wisely. There are cases which require the targeted chemotherapy, and there are cases which require intravenous chemotherapy. So all forms of chemotherapy work, but not in all cases, all forms of chemotherapy are required. So with this, I end my talk. Thank you very much.
Yeah, thank you, Swati, for wonderfully elucidating all those pits and pearls in retinoblastoma management. So we have 3 more minutes. Any question for any of the speakers from the audience? Yeah. Hi. So mitomycin C, as you correctly said, is definitely an option for pharmacologically treating OSSN. But the problem there is availability, everything being cheap, no storage issue. But the problem is the ocular surface toxicity. So there is a lot of ocular surface toxicity with mitomycin C. So these days we have moved on to 5-fluorouracil because of a safer ocular surface tolerability compared to mitomycin C. But efficiency-wise, it is also good. Any other question for any of the speakers? If not, thank you everyone for a patient listening. We hand over the session to the next IC, for the next IC. Thank you.